Hello and welcome to this webinar on active aging in LGBTQ plus people over the age of 50. My name's Michael Brady. I'm a sexual health and HIV consultant. I work in South London. I'm also the National Advisor for LGBT Health at NHS England, and I currently am one of the co-chairs of the British PrEP Guideline Writing Committee. And I'm going to be presenting this webinar with my colleague Laura, so I'm just going to hand over to her to introduce herself.
Hello, thank you, Mike, and good evening, everyone. I'm Laura Waters. I'm a doctor in central London. What do I do, Mike? I was previously chair of BHIVA, but I'm now the National Specialty Advisor for HIV to NHS England, and I'm involved in HIV testing and other guidelines on behalf of BHIVA and BASHH.
Thanks, Laura. So I'm going to start off by taking us through the first half of the session. We're going to be focusing on a number of topics related to HIV, aging, and the LGBTQ plus community. We're going to think about testing. We're going to think about prevention, particularly pre-exposure prophylaxis, HIV treatment, and stigma. So before we start there, we've got a couple of questions. I should also say that there's going to be some questions scattered through the session to give you an opportunity to test your knowledge pre-talk and post-talk. So I've got two questions for you before we start, just to take a few seconds to think about. So first of all, the first question is, I discussed the need for HIV testing with my older LGBTQ plus patients, and just answer whether that's never, rarely, sometimes, often, or always. I'll give you a few seconds to do that before we move on to the next one. And this second question is, I assess the mental health of my LGBTQ plus patients over the age of 50. And again, just answer whether that's never, rarely, sometimes, often, or always. Okay, just to also just briefly say, we're duty bound to say this educational activity has been supported by an educational grant from Gilead Sciences, but that is free of influence from any commercial entity. So we have four learning objectives for the session, which are being able to describe strategies to overcome barriers to HIV testing in older LGBTQ plus people, to be able to describe the indications and contraindications for PrEP, pre-exposure prophylaxis for older LGBTQ plus people, to describe the benefits and drawbacks of rapid antiretroviral therapy initiation, and to be able to assess factors associated with aging that may complicate treatment or warrant special considerations. So starting off with some context, before we get into the HIV, just thinking about LGBTQ plus people, we know from the 2021 census that around 3.5% of respondents identified as lesbian, gay, bisexual, or another minority sexual orientation. And for the first time in 2021, the census asked questions about gender identity, and about 0.5% of respondents stated that their gender identity was different from the sex that was registered at birth. And before we get into the issues and stigma relating to aging and relating to HIV, it's important to remember that LGBT plus people face considerable barriers to leading happy, healthy, and fulfilling lives, which impacts on their health and it impacts on their health-seeking behaviour. Societal factors such as discrimination, bullying, and harassment in pretty much every setting in society does impact on how people interact with healthcare. And we know from the data that we have that pretty much without exception, LGBTQ plus people face greater inequalities in terms of their satisfaction of healthcare, their access to healthcare, their experience of healthcare, and frequently their clinical outcomes. And we know from surveys and research that LGBTQ plus people report poorer communication and interactions with healthcare staff, language that is frequently not inclusive of them, assumptions of heterosexuality, and frequently still, unfortunately, overt discrimination. It's important to remember that when we talk about the LGBTQ plus acronym, it's a very diverse acronym with a mixture of sexual orientations and gender identities, but it's probably also fair to say that trans, non-binary and gender diverse people report the worst experiences of all of those within the community. And in healthcare, that can be as a result of gendered materials, such as leaflets which are aimed at women being given to trans men, very gendered spaces which can be off-putting, such as maternity units, a lack of recognition of the importance of the use of correct names and pronouns, and even just infrastructural things like IT systems that cannot record their correct gender. And this overall can lead LGBTQ plus people to feel that they're not included in the services are not designed or welcoming to them, that they don't have the relevant information or services, and have an expectation, sometimes not unreasonably, of being treated badly or differently when they access services. So before moving on to the first part, which is going to be about HIV testing and diagnoses, we've got a video for you to watch where we're going to hear from a patient about their experiences.
I've been living with HIV since I was 17 and received my diagnosis in 1986.
Being around since the very beginning and losing friends and family from the early 80s, it was always like, oh, when is the hammer going to drop? Are you next? Because it was a death sentence when it first arrived on the scene, and everyone that was on the scene felt they were under a death sentence.
Aging with HIV is an exciting and interesting challenge. First of all, it wasn't something I expected to happen, because my diagnosis was to probably reach 18 or 19. So I'm really glad to be here.
With HIV and the length of time I've had it, I feel that my body has been aging quicker than those of my contemporaries of the same age.
When one is HIV positive, you often think any ailment that happens to you is related to your HIV. It's your go-to. It's the first thing that you start thinking of, and that has a lot to do with the stuff that you have internalized over your journey with HIV. So whenever I've been unwell, I have immediately gone to, is this to do with my HIV?
Most doctors will look at you as the age of my contemporaries, not the age of someone who's got a comorbidity with HIV and other factors.
When I was diagnosed at 17, I told my family and received a lot of love and a lot of support, which I think is really important to tell people that that does exist. And I think that that love and that support and that blanketing around me, a great big comfort blanket of my family, has enabled me to live well and to deal with many of the challenges that life and my HIV have thrown up at me.
Okay, so this is the first of the knowledge questions. Again, these are going to be scattered through the session. I'm going to give you a few seconds just to look at this and answer this. Approximately what proportion of people over the age of 50 who receive a new HIV diagnosis are diagnosed with HIV late? And by HIV late, we mean people who've got more advanced disease, i.e. a CD4 count of less than 350. So what proportion of people over the age of 50 are diagnosed with HIV late? The answer to this is going to be coming up in one of the following slides, and then we'll ask you the question again. Okay, let's move on. So we're going to focus on HIV testing. So first of all, thinking about what some of the barriers to HIV testing are. They're multiple, and individuals can experience or have more than one at any one particular time. But it may be about perception of risk. So HIV is not something that could affect me, or it's other types of people that get HIV. HIV stigma is a considerable barrier, not just to HIV testing, but also to then people engaging in care and having the confidence and the ability to keep coming to see us and taking their tablets regularly. It may be about a fear of a positive result. Still, there are myths and misunderstandings around HIV. People still think about the terrible days of the 80s and the 90s, and not everybody knows that now people living with HIV can have normal life expectancies and won't transmit the virus to others. So it may be about the fear of the consequences of a positive result. It may just be practical. It may be difficult in terms of accessing services, or it may be more general in terms of an individual's more broader health-seeking behaviour and competing priorities. You know, if you're living in poverty, or a migrant who's claiming asylum, or is struggling to put a roof over your head or food on your table, then coming to access any kind of healthcare, whether that's HIV testing or anything else, may not be the top of your priority. People living with HIV are aging, pretty much as a function of effective treatment. People over the age of 50 now account for about half of all people living with HIV. people over the age of 50 account for about 1 in every 5 of newer diagnoses, but about half of people aged over 50 are diagnosed with HIV late, when they've got a reasonable amount of immune dysfunction as a result of the HIV infection. So we're not getting to them soon enough with a test that's acceptable for them to be diagnosed at an earlier stage. When we're thinking about HIV transmission, this is some data from the States which pulls out, I think, 2 key points, one about testing and one about the importance of engagement in HIV care. HIV transmission is more likely to occur when somebody has a detectable viral load. So that's somebody who is either unaware of their HIV or is aware of their HIV but isn't on effective HIV therapy. In other words, their viral load, their HIV virus, is not fully suppressed. And this is highlighted really nicely in this study, where the 2 commonest causes of an HIV transmission occurring were either those who were HIV infected but didn't know about it, in other words, undiagnosed and hadn't had the opportunity to have an HIV test. That was about a third. But the single commonest cause of an HIV transmission were those who were aware of their HIV infection, but for whatever reason were not engaged in care and not on effective treatment, and therefore had a detectable viral load, which caused the transmission to occur. HIV testing is the foundation of both HIV prevention and HIV treatment. It all starts with the HIV test, which is why the HIV test and doing the HIV test is so important. If you're HIV negative, then you can access really effective HIV prevention strategies like PrEP, pre-exposure prophylaxis. You can be encouraged and supported to repeat your HIV testing regularly and to continue to reduce your risk of HIV and stay HIV negative. And if you're HIV positive, then you can access really excellent HIV treatment and care services, really simple, easy to take, and with low toxicity HIV treatment, which very quickly can suppress your virus and mean that your immune system can recover. You don't get ill. You can expect a long and normal and healthy lifespan, and you can be confident that you won't pass the virus on to your sexual partners. That's what U=U means. Undetectable equals untransmittable. Those with a fully suppressed HIV viral load as a result of HIV therapy do not transmit the virus to their sexual partners. So whatever the result, whether it's positive or negative, there is an action that you can take. That may be taking PrEP or other risk reduction strategies such as condom use or thinking about partner change or partner modification. And if you're HIV positive, as I said, there's both treatment but also the importance of partner notification, being able to identify other partners who may be living with undiagnosed HIV. And so when we're thinking about principles of HIV testing, it is really very simple, and that's really the take-home message. Anybody can do it, and anybody should do it. There's no longer the need for detailed pre-test counselling. There's just a bit of basic information, much of which can be given on websites or in leaflets, and doesn't even need a healthcare professional, with the principle of opt-out. So encouraging testing in as many settings as possible, rather than waiting for people to come and ask for a test. Some simple information about how people will get their results or the support that they will get around a result, whether that's negative or positive, and then the importance of linkage into care. So if a test is reactive or positive, what are the ways and how quickly can an individual be brought into HIV services for treatment? So we have national guidance around testing that have been around for a long time. We're probably still got a way to go to meet the recommendations of the UK HIV testing guidelines. But when we're thinking about who to test, there are some settings when we should be doing routine testing. So it should be part of standard of care. So this has been shown to be extremely successful for more than 2 decades now in antenatal settings. Pretty much every pregnant woman in the UK now gets an HIV test, because if we know that a woman who's pregnant is HIV positive, we can prevent transmission of the virus to the child. So that's the model that has worked extremely well, and now we're trying to move into other settings. So the guidelines in the UK recommend a similar approach to routine opt-out testing in both primary care and acute care settings, so emergency departments, for example, where diagnosed HIV prevalence is high or very high, and that's defined as high is a diagnosed prevalence of greater than 2 per thousand, and very high is a diagnosed prevalence of greater than 5 per thousand. And just over 20% of local authorities in England have high or very high prevalence. Then we think about risk groups in terms of targeting testing. So that is particularly gay, bisexual, and other men who have sex with men, injecting drug users, and people from high prevalence areas, so particularly those from sub-Saharan Africa. And then there are clinical settings where we know that people attending are more likely to have HIV, and where we should be thinking about doing routine and opt-out testing. So that would include sexual health services, reproductive and contraception services, abortion services, drug dependency units, hepatitis and oncology services. And then also thinking about people who may have conditions which are suggestive of HIV. There is a long list of what's called HIV indicator conditions. These are just some examples. They're very easy to find with a quick Google. The BHIVA testing guidance has a really nice table at the back. I think the important message about this is that HIV indicator conditions are not necessarily really severe AIDS-defining illnesses, those rare diseases that you wouldn't expect to commonly see, particularly in somebody who has a competent immune system. Simple, common things that we see quite frequently, like cervical dysplasia, bacterial pneumonias, blood dyscrasias, peripheral neuropathy, dementia, should all be making us think about doing HIV tests. The other thing that's important to remember, or to note at least, is that HIV testing technology has evolved considerably in recent years, mostly to address many of those barriers that I talked through just at the beginning to HIV testing. So on the left-hand side, you can see some of the newer technologies. So simple point-of-care tests where you get a result pretty much straight away in sort of 2 to 15 minutes, which can be done either on a finger prick or on a saliva test. There are now self-testing technologies which are done on a finger prick, so people can just order a test online, do it themselves at home, read the result themselves in the same way that they would do a pregnancy test, for example. And on the right, you can see sort of what we'd perhaps call traditional testing, so blood-based serology, where we take a blood sample and then send it to the lab for testing. And then also there's what we call self-sampling, so finger prick testing, usually ordered online, where the patient does it themselves and then it's sent to the laboratory for testing. And essentially this means that almost any barrier can be overcome. If you're a bit needle phobic, you could have a finger prick. If you're extremely needle phobic, you could have a saliva test. If you can't get into or don't want to get into a clinic, you can do a self-sample or a self-test. If you don't want anybody else to be involved in it, you can order a self-test for yourself. So ramping these up and rolling them out and making sure people are aware of them are a key factor to increasing the uptake of HIV testing. And you'll see on the slide there that I've put down where tests are 3rd generation and 4th generation, and we're going to come on to what that means now. So when thinking about a test, we think about what is perhaps preferable or what is most acceptable to an individual. So a 4th or 5th generation test is perhaps preferred. These are the most sensitive and specific. A 4th or 5th generation test will look for both HIV antibody and HIV antigen, what's called P24 antigen. So it looks for a bit of the virus as well as the antibody immune response to the virus. These are more accurate, more sensitive, more specific, and have a smaller window period. So we'll detect an infection sooner after it's been acquired. If you're suspecting HIV seroconversion, primary HIV infection, so somebody who's been infected very recently, the test may be negative, but think about doing an HIV viral load. So that's something where it's a test that looks for the virus and doesn't rely on antibody production. As I said, point-of-care tests and self-sampling and self-testing is increasingly being used, are very acceptable, very convenient, and very confidential, and they've been shown in a number of evaluated studies to increase uptake of HIV testing in people who've never tested before. They're quick, they're cheap, but they do have a longer window period. So the window period for a point-of-care test and for a self-test is 12 weeks, not 6 weeks. They also have a lower sensitivity and specificity. So on point-of-care tests and self-testing, we talk about a reactive test, and it needs to be confirmed with a 4th generation serological test. So just to say a little bit more about the window period, so we're all really clear about that. Essentially, the window period is the time from infection to getting a reactive or positive result. As I've said, 4th generation tests, which are done in the laboratory, have a 6 weeks window period, and non-laboratory tests, so point-of-care tests and self-tests, have a 12-week window period. The window period should never deter you or defer testing. So never say to somebody, oh, you're in the window period, come back in a few weeks' time to test it. The window period should be used to advise when retesting is required if somebody is testing within the window period. The simple way to remember the window period is if a sample is going to the laboratory, it will be a 4th generation test. If it's not going to the laboratory, it will be a 3rd generation test. So it is also all in the approach that we take. So how we talk about HIV tests it can either deter or encourage somebody to test. So normalizing it, we'll be doing some blood tests, and one of those will be for HIV, is an encouraging way. Saying, oh, you don't need an HIV test, do you, is never going to get anybody to test for HIV. Sometimes it just needs investment, and I think it is worth just on this simple slide just noting that. So this is some data from the first year's evaluation of a rollout of opt-out HIV testing in emergency departments, which was funded in 2022 to the tune of £20 million and has recently been expanded. So this is opt-out testing now in multiple A&E departments around England that are in areas of high or very high HIV prevalence, frequently including testing for other blood-borne viruses like hepatitis B and hepatitis C. And there are hundreds of thousands of tests, millions of tests now being undertaken, and many new diagnoses, and also many people who had previously been diagnosed but disengaged from care being re-engaged in care. Okay, so this is the knowledge question that you saw before. So just a few seconds for you to answer that now. Hopefully you'll be able to feel more confident and get the right answer now. Approximately what proportion of people over the age of 50 who receive a new HIV diagnosis are diagnosed with HIV late? Okay, we're going to move on from testing now to thinking about HIV prevention. So another question for you. The answer will be at some point in the next few slides. Which of the following is an absolute contraindication to PrEP? Continued injection drug use, hepatitis B, pregnancy, a reactive HIV test, or use of gender-affirming hormones? Which is an absolute contraindication to PrEP? Okay, so pre-exposure prophylaxis. This is the use of drugs that we commonly use to treat HIV, to prevent HIV, so taken before and after sex. And it's been demonstrated both in studies and real-life experience to reduce the risk of HIV acquisition by about 99%. If that's for sexual exposure, and about 74% reduction in risk for people who inject drugs. It is incredibly effective at preventing HIV, but doesn't protect against other sexually transmitted infections. And the benefits of PrEP are rapid and substantial. Pretty much within a couple of hours of taking the tablets, you are protected from getting HIV. It's very well tolerated, and any toxicities that are seen are predictable, delayed, uncommon, specific, and reversible with the correct monitoring. I'm not going to go into this in too much detail because you will get the slides, but it's just really just to make the point that the two main things that we consider, and particularly the main one, is renal function with oral PrEP. So in the studies and in real life experience, a good renal safety has been seen for the main drug that we use in PrEP, which is called tenofovir. It's not uncommon to see some mild progressive renal impairment, usually not clinically significant and usually manageable or reversible. And therefore, it's important to assess the risk of chronic kidney disease at baseline and to monitor for it and to look for factors that may increase the risk of renal dysfunction, such as people who are older. So that applies to people over the age of 50 that we're thinking now, people who've already got renal disease or have other conditions that might affect their renal function, such as hypertension and diabetes, or are also on nephrotoxic drugs. There's also, and this is something that we know from using tenofovir in people living with HIV, a small but significant reduction in bone mineral density in people taking tenofovir-based PrEP for placebo. There's no evidence to date of there being any increased risk of fractures, and it's usually recoverable and manageable with dose reduction or stopping of the PrEP. So 2 things to consider about PrEP. We now have 2 out of 3 of these available in the UK. So Truvada is the brand name. We don't actually use Truvada, the brand, anymore, because now we have generic versions of tenofovir FTC. That's the first tablet on the left, which has made PrEP much, much cheaper than it used to be. Recently available is 𝗪𝗂𝗶𝗍, which is a slightly different, includes a slightly different form of tenofovir, 𝗳𝗏𝗏 rather than tenofovir-diazoxide, which is much more favorable on kidneys and bone, and so is now being increasingly used in limited people, mostly in those who've got some renal dysfunction. And then it's also just important to be aware that there are new modes of PrEP delivery, particularly injectable PrEP, so 𝗪𝗪𝗪𝗪 long-acting PrEP, which has been shown in 2 large randomized control trials in men who have sex with men, in trans women, and in heterosexual women to be superior to oral PrEP. It's much more expensive, and it's not currently licensed in the UK, although it's going through the regulatory process. So we have increasing ranges or numbers of PrEP things which are PrEP which is available. I won't go into this into too much detail now because it's easy to go off and read yourself, and you'll get the slides, but this is just the reflection of the current national guidelines for PrEP. These have just been updated and will be out for public consultation coming soon, but currently we'd recommend PrEP for gay men and trans women who report condomless sex. In fact, anybody who's reporting condomless sex in somebody who's HIV positive but is not on antiretroviral therapy with a suppressed viral load, and in other people who have other factors which may put them at increased risk of HIV acquisition. Our new guidelines are going to take quite a shift away from that because some of those eligibility criteria have actually, I think, been a barrier to uptake of PrEP. So we're now moving away from eligibility that's based solely on previous PrEP trial eligibility criteria, and now really saying, give PrEP to people if they ask for it. Give PrEP to people who are at risk of HIV, which we define as being greater than the background population, irrespective of their gender, sexual orientation. And now another change is to recommend for anyone who's injecting drugs or sharing injecting equipment. There is really only one absolute contraindication to PrEP, and that is somebody who has HIV. 2 PrEP drugs are not potent enough to treat HIV, so you don't want to give them to somebody who's already got HIV. So you need to confirm that somebody is HIV negative with a 4th generation HIV test. And if somebody presents with signs of symptoms of HIV seroconversion, then you would want to make sure that they are not seroconverting before you start them on PrEP. But essentially, there are really no other absolute contraindications. They can be used in people who are pregnant. PrEP can be used in people who are breastfeeding, on gender-affirming hormones, have hepatitis B, or are continuing to inject drugs. Which brings us back to the knowledge question, which hopefully will be a little bit easier for you now. Which of the following is an absolute contraindication to PrEP? Continued injection drug use, hepatitis B, pregnancy, reactive HIV test, or use of gender-affirming hormones? And as you're doing that, I'm going to hand over to Laura.
Thank you very much indeed, Mike. Can you hear me yet? Oh, there I am. Hello. So hi, everybody. Laura Waters again. So for parts 3 and 4, we are also starting off with a short video. This first one is thinking about treating older people living with HIV. So over to the video.
But what I am finding increasingly is that when I go into spaces, particularly healthcare, I'm having to educate some clinicians, some practice nurses about aging and HIV, and to recognize that being on medication for 20-something years, living with a virus for 35 years has taken its toll on me.
What I would say to clinicians is the best thing they can do is listen to the patient, because they will have experiences that the clinicians may have learnt about or seen similar things in others, but every patient is separate, and there may be something else that links their original condition, and by listening to them you can then figure out various things that may be one of the answers.
As we age, we bring a lot of life experience and a lot of knowledge from different areas of our lives. So to speak to patients, to understand what skills and tools that they have developed to manage their condition over their journey, And that may be a very long journey like mine, or it may be they're recently diagnosed and they can dip into other areas of their lives. And the third and final thing that I would say for clinicians is to try to link patients who may be isolated with peer support, with other people who are living with HIV.
The biggest thing they could just start doing, see the patients and start getting involved in their treatment and pushing it forward, just as you would, as a GP would for anyone who came with any issues, whether they were physical or mental issues. They'd help them, wouldn't they?
What I've done is to educate not necessarily my HIV providers, but general practitioners about the intersection of aging and HIV. And I think I've done that through just simply trying to make sure that they're aware that I'm positive, I live with HIV, and this may be having an impact. So I want them to make sure they're looking at absolutely everything and they're taking my HIV into account, whether that's the physical impact or the emotional impact of living with the virus.
Brilliant and eloquent words. So we're going to have some more knowledge questions now. So question 3, which of the following best describes when all people with HIV should be offered an opportunity to start antiretroviral therapy? We have within 2 to 4 weeks of diagnosis, when the person experiences symptoms, when they become sexually active, or when an opportunistic infection develops. I'll give you a few moments to answer that first question. Fabulous. So let's move on. And your second knowledge question, the REPRIEVE trial showed with active treatment a 35% reduction in renal disease, loss of bone mineral density, major cardiovascular event, or HIV viral load. Please choose one of those 4 options. And again, I'll give you a few moments to do so. Right, let's crack on. So, generally speaking, certainly compared to the early days when Mike and I first worked in HIV medicine, HIV therapy is generally fairly simple and easy to take. And by and large, we're using drugs with relatively low levels of toxicity. And ultimately, early diagnosis, timely initiation of treatment, and maintained adherence achieves viral suppression, and that equates with a normal life expectancy for many people, and really importantly, a 0 risk of transmission to their sexual partners. Let's embrace that word, 0. We know that treatment improves both physical and psychological well-being for people with HIV, and certainly in the UK, almost everybody with HIV diagnosed is on treatment, and the majority of those are virally suppressed. So when should you start treatment? This is from the excellent British HIV Association guidelines, and people should start or be offered the opportunity to start within 2 to 4 weeks, but discussing their readiness to start is absolutely important. Now, you may be thinking everybody should be put on same-day treatment, and there are some specific clinical scenarios where that is the case, such as primary HIV infection when people are symptomatic in the very acute phase of HIV acquisition. But also if someone's ready to start same day, that's absolutely fine. But I think we must be clear that there perhaps has been a bit of an assumption that same day treatment is necessarily better than waiting for 2 to 4 weeks. And in general, that's not the case. And some of the evidence showing benefit of same day ART is primarily from low and middle income country settings. There's no randomized data from high income countries. What data there is comes from cohorts, and they show variable results. In Taiwan, retention in care was better with same-day treatment. In France, it was worse. So it really is an individualized decision, and if someone wants to start on the same day, which many people do, then that's something we can absolutely support. Now, if you are thinking about what art to select in general, these are, of course, some of the key things you need to think about. Other conditions listed here, other medications, that's thinking about overlapping toxicities, but particularly drug interactions. And when we're thinking about older people, we do need to consider the impact of age on the pharmacokinetics of some of those drugs. So there are some changes with how the body handles various drugs, and renal elimination, for example, may reduce with age. So that's why it's important, of course, to review people, their symptoms, their results, and their other conditions over time, because something that suited them in their 30s and 40s may well not be the best option for them as they get older. Now, when we're coming back to that rapid art, what do we do if someone's decided that rapid art is the option for them? Well, of course, there's some of the baseline information that we wouldn't have available. HLA testing, if you're considering an 𝗵𝗂𝗶𝗴-based regimen, potential for transmitted resistance, and their viral load and CD4 count, which may impact some of your first choices, certainly in the BHIVA guidance. And so what BHIVA recommends is starting a high barrier regimen, and that means a 3-drug regimen using a tenofovir-based 2-NRTI backbone with a 2nd-generation integrase or boosted darunavir for dolutegravir, bictegravir, or boosted darunavir would be the choices. Now, thinking more broadly about aging with HIV, then we need to think about the intersection of HIV-associated or HIV-enhanced issues, and they are listed there, including some important physical, but also social and psychological issues. And then aging in general, and there is, of course, an overlap. There is an overlap, and we need to think about the additive effect of HIV medication toxicity. Now, whether it's HIV per se, aging, or drugs driving those toxicities, the important thing is to monitor them and make sure that we can mitigate them wherever we can. So some other considerations, thinking about specifics, I won't go into this in great detail because, again, as Mike said, you will all have a copy of these slides, but cardiovascular disease is definitely back in the headlines. It is, of course, probably the most important cause of morbidity and mortality globally now, and we use the Q risk calculator in the UK because it's based on UK data, but the important thing is to assess someone with HIV's cardiovascular risk regularly. But think about renal and bone disease, of course, tenofovir-disoproxil is one of the drugs we consider there, though of course tenofovir-disoproxil does remain a very reasonable option for many. And thankfully we are not starting people on efavirenz any longer. That was the greatest culprit when it came to central nervous system and mood symptoms, but it's not the only drug that can, and assessing people's response to any drug is critical. Moving on. So coming back to the cardiovascular disease, and this is going to answer that second question for you. So REPRIEVE was a very big study, indeed the biggest study ever undertaken in people with HIV, and it was presented and published last year. So more than 7,500 people with HIV with no history of cardiovascular disease, and actually an average low risk, so their average risk at baseline was 4.5%. And if we think about in England, for example, we recommend statins for primary prevention at a threshold of 10% or more. This was a relatively low risk group. So people were randomized to receive pitavastatin or placebo, and they were followed up looking for major adverse cardiovascular events. Now, the study was stopped early. By early, that was still a follow-up of 5.1 years, which I think in the HIV field we'd consider quite a long time. And it was stopped early because people on statins saw a 35% lower risk of major adverse cardiovascular events compared to those on placebo. Now, there was a slightly higher risk of diabetes in the pitavastatin group. However, this is a well-known effect of statins. And actually, there's some debate about how you measure insulin resistance, how you categorize diabetes. And one very big study of primary prevention with statins, which is exactly what this study looked at, called JUPITER, showed that on average, statins accelerated onset of diabetes by just 5 weeks. So the assumption is that many of these people would have developed diabetes anyway. And of course, diabetes is a condition where you might want to consider a statin. So overall, the benefits are very much considered to outweigh the risks. 35% reduction in cardiovascular disease, and the British HIV Association updated their guidelines at the end of last year to recommend offering a statin to everybody over the age of 40, and the DHHS in the US published very similar guidelines just a couple of weeks ago. Statins can interact with antiretrovirals. Now, pitavastatin was chosen for its low propensity for interactions with antiretrovirals. It's not available in Europe at the moment. We're recommending a 𝗤𝗏𝗧𝗏 20 milligrams that can interact with some of the antiretrovirals. So, of course, using the Liverpool tool to look at that interaction, as we should with any potential interaction with newly prescribed meds, is important. And increasingly, I see people in clinic who've got this on their phones so that they are in control of their medication, and they can tell healthcare professionals whether there's an interaction or not. So I shall now move on to the final section, which is stigma, and that brings us to our third and final video.
So the stigma I faced or perceived or experienced when I was diagnosed in the 80s was really, really high level. It wasn't just in my personal networks, it was across society. So in the media, in healthcare, across the board, I could expect to experience stigmatizing attitudes or behaviors from people.
For those that were around at the very beginning, there is a large amount of stigma because basically the whole society was against the gay community, and also within the gay community there was also stigma.
I mean, for me, growing up in the 60s, 70s, and 80s, the environment was an awful lot more hostile.
That trauma builds up over the years, and even though it has lessened, there is still stigma now.
So, for example, I've experienced stigma with my primary care setting, not from the physician, but from people who may work on reception. So there is still out-of-date knowledge amongst some groups, and that is my concern as I get older.
Things have got better, but the stigma from those who had it or who were around earlier on is still there, and it's deeply seated, and it's hard to get rid of that trauma.
The one way we will stop those with a different agenda, a more offensive and nasty agenda towards LGBTQ plus people, is by being open and being seen, and showing people that us normal human beings.
Fabulous. What another poignant note to finish on there. And I think I'm always grateful to the people who are happy to be open and visible, because not everybody is able to, not everybody wants to. And yet I think the bravery some people show in being there and being open and helping to inspire change to benefit others, I think is laudable. So unfortunately, HIV stigma is a global issue, and we know it's a big impediment to reaching the goals of testing, engagement, and getting people and keeping them on treatment. But of course, there's both external and internal stigma. External stigma is probably one that's most obvious and visible, but the internalized feelings of shame and guilt that so many people with HIV experience are another facet of it. There's lots of work on this. We know that stigma is associated with more isolation, depression, lower self-esteem, less disclosure or sharing of HIV status, and more likely to engage in sexual behavior that may put them at risk of other conditions. And all of this adds up, of course, to have a negative effect on people's psychological well-being. And there's lots of intersection here, and there's lots of layering. This 5 corners model illustrated here, I think just to pause and look at that, and again, you will have these slides rather than have me waffle through it. When you think about people that you see in your service and how many of these different elements will apply to them, you can see how all of that will add up to create an increased stigma picture. Now, the Positive Voices survey, this is led by the UK Health Security Agency. This is a second version of the survey, first undertaken a few years ago, and it's a big representative survey, more than 5,000 people, and they ask a lot of questions. And there's some really quite sobering facts here that actually the majority of people with HIV don't feel able to share their status with most people in their life, and 1 in 10 had told nobody beyond healthcare staff. Almost half felt ashamed. A third experienced low self self-esteem. And really concerningly, 7% actually avoided accessing healthcare services. Now, we talk a lot about late presentation of HIV, but late presentation of other conditions can, of course, be associated with much worse outcomes. So when we're addressing stigma in older people, I think we must be aware of those intersections, and particularly when it comes to sexual orientation, gender identity, age, and HIV, as we heard so brilliantly in that video. That to discuss and address stigma with people, because being able to tell us about it means that we can help find a solution. But of course, normalizing HIV through the language. Now, many of us in the field, or all of us in the field, are passionate about using the right language. There's a People First Charter website is something I set up a few years ago that summarizes some of the language, but I think increasingly it's initiative. It's not a new ask. Many of the community groups have been flagging appropriate language use for many, many, many years. But if this is something that you're not very familiar with, do have a look at the People First Charter website. And we need to look for strategies to provide advice, information, and peer support. Sharing experiences with people who've had similar experiences to you is absolutely invaluable, and it's why peer support really is so well embedded and should be embedded even better in our services. So moving on to a couple of more knowledge questions. No, in fact, we're moving on to the repeat of the questions. Do forgive me. So, of course, the answers did pop up during my slides. So just to refresh these, question 3, which best describes when people with HIV should be offered treatment? 2 to 4 weeks, symptoms, when they're sexually active, or when an opportunistic infection develops. So please answer again now. And then moving on to question 4, which was the one about reprieve, 35% reduction in renal, loss of bone mineral density, major cardiovascular event, or HIV viral load. We're expecting 100% correct on this one. Give me a couple more moments. And moving on, thank you.
I will now discuss the need for HIV testing with my older LGBTQ plus patients. Never, rarely, sometimes, often, or always. I don't think these are going to display, but just gives yourself a little bit of an internal checklist. And then the second one is I will now assess the mental health of my LGBTQ plus patients over 50. Never, rarely, sometimes, often, or always. So just whilst you're doing that, a reminder that you can post questions using the Q&A function. We have about 10 minutes to go through some questions. So on any of the topics we've covered, or anything else, I guess. So let me start. Let's have a look at what's coming through. Laura, let me ask you this question. We've both briefly touched on the importance of antiretroviral therapy as prevention as well as treatment, sort of a biological approach to prevention. And we both touched on U=U, which I think is still a concept that's not fully understood by patients, or by healthcare professionals. So could you tell us a bit more about U=U?
No, absolutely. And so it's a really good point about we talk about U=U as if everybody knows what that means. And I'll give an example in a moment of how that often or sometimes isn't the case. So back to the point. So undetectable is untransmittable simply means if someone has an undetectable viral load, so they're on effective therapy, we know the goal of HIV treatment is viral suppression. And if the virus is undetectable in someone's blood on their routine testing, it means there is zero risk of sexual transmission. Now, this has been a long story. We've known over the years that the higher someone's viral load, the higher the risk of onward sexual transmission to their partners. And we had some evidence that people with an undetectable virus were highly unlikely to pass it on. But it took a big randomized trial and then some really well-designed cohort studies to really get everyone convinced that zero was the risk. And I think in medicine, it's very hard to say zero. We're taught at medical school that you never say never and you never say always, that there's always a tiny risk. So I think the problem was with the scientific and medical establishment, because actually it's the community that embraced these trial findings way before the rest of us did. It was the community that pushed for a zero risk of transmission to be embedded in all guidelines and all consultations and all narratives. And it's a reflection of how long it took that although many organisations have been endorsing the 𝗂=𝑈 message for several years, the World Health Organization only finally said 0 last year. So I think that's indicative of how long it took to enact change. But what that means, undetectable, which actually means a viral load below 200. There's always been debate about what undetectable actually is, but someone with a viral load below 200 can be confident that there is no risk at all. And coming back to the example, I spoke to a patient and we talked about 𝗂=𝑈 a couple of times, and there were posters in the clinic, and then there was something in her face one day and I was like, do you know what that actually means for you? And actually she didn't. And when we talk through, you can have sex with no risk. What, even without condoms? Yes, without condoms there is no risk. You might still want to use condoms for other reasons, of course. And it actually made me think that going back and checking, not that just someone's heard of 𝗂=𝑈, but that they actually know what it means is so important.
You're absolutely right. And when people do understand it, it's game-changing and life-changing for individuals, and it's so impactful, so really important. And I think it also reinforces that point about language that's so important. You mentioned about the People First Charter, which is more broadly about how we. Which no, it's good. People should know about.
I do a plug for that every time I can.
𝗂=𝗏𝗏𝐻𝑐harter.org. Go and find it. But the language about absoluteness on transmission risk is so important, because people have to have confidence. So we don't use low risk or negligible. We say 0 for sure. I wanted then also just to ask you, thinking about starting antiretroviral therapy or continuing antiretroviral therapy, and you quite rightly made the point about it's all about readiness, which can be different points in time for different people. But what's your approach to support somebody who perhaps isn't ready or is struggling to start or is struggling to continue on antiretrovirals?
No, it's a really good question, and I'll say what I think, and then I'm also going to bounce that back to you, because although I think a lot about our clinical service is very similar, I think because we work in different parts of London, we also see people with some quite differing challenges. I think the first thing is it's actually now not a very common issue. It's certainly a conversation that I'd have had far more often. I first started working in HIV in 2002, and it's a conversation that happened more then, but also there was less certainty about everyone should be offered treatment straight away back then, and we were relying on CD4 count to decide when to start. But it's something that's difficult because it's not much evidence to guide us here. We've got evidence that starting sooner is better for a population, and we can say to people it's good for your individual health. I think in the modern era, it's quite hard to say to somebody your risk of X happening if you don't start treatment is whatever. We just don't have that evidence. And I think we've all got people where we've done the scaremongering stories and they've carried on for many, many years before anything happens. So I think it's something you need to frame quite carefully. Now, it's a new section in the BHIVA treatment guidelines. So there is a whole section in those talking people through how to approach it and how to support people to start. So I encourage people to have a look at that particular section. But what I tend to do is talk through in very simple terms the evidence. I talk about the evidence for them as an individual, talk of course about evidence in terms of risk of onward transmission, and talk through their fears. What is it that's stopping them wanting to start treatment? And actually quite often then the next best person to see them isn't me. So it may be an issue whereby we're very lucky to have a psychology team where a discussion of the psychologist will help. It may be that actually one of our specialist nurses who may be a bit more adept about talking about how to manage adherence challenges than I, or coming back, probably the most important group is our peer support workers, and to be able to again speak to somebody who may themselves have had issues about starting treatment and had their own fears, but can also share share how it is for them, I think is absolutely critical. Agreeing a monitoring plan. And I think for some people who've got real concerns about starting treatment, it's about kind of agreeing some thresholds. And I find some people will start if their CD4 count drops to a particular level or if something else happens. I think one of the big advantages now is we do have more options than tablets. And with, we have one injectable treatment available at the moment. Hopefully, as we move into the future, we'll have more and more long-acting options. And so for people who really fear taking pills, right now we can say, okay, well, if we can find a way to get you on pills and get your virus undetectable, there is the potential option of switching to something long-acting. And that in itself may be something that opens up options for people and removes some of those barriers to starting. So I'm going to bounce it back to you now, Mike, and how do you approach it?
Well, I don't really have anything much more to add to that. I mean, I think other than just re-emphasizing and highlighting that it's often a non-clinical approach that is more important. Obviously, all of that clinical monitoring support and information is important, but it's the DT, it's the nurses, it's the mental health, it's the peer support, it's the wider team to address those social or mental health or non-clinical reasons that people are struggling with their therapy. So.
Actually, Mike, one thing to add there, because you're absolutely right, because when people are drowning with other issues, health is often the lowest on their list of priorities. And I think considering some of the extreme social, housing, financial issues that many people are facing, but disproportionately impacting people with HIV for many reasons, helping where you can, recognizing that we have limitations, but I cannot overstate the power of a letter from a healthcare professional when it comes to supporting people as they try and navigate benefits, housing, asylum, etc. Never think that a letter from a healthcare professional doesn't make a difference, because I really think it can. And investing some time, personalizing that kind of plea for help, I think can be really helpful.
Absolutely. I might ask myself a question now, because it's a PrEP-based question.
I should have had a question for you, but yes, ask yourself a question.
I thought I ought to take this as I do the PrEP guidelines. Anyway, what is event-based PrEP and how is it prescribed? So we talked a little bit about PrEP efficacy and safety, but it is important to know that there are different ways that you can take PrEP. You can take PrEP daily, so that's taking a tablet every day, or you can do event-based. And this was studied in one particular study called the 𝗂𝗑𝗍 study that looked at dosing where you take a double dose between 2 and 24 hours before you have condomless sex, and then take a single dose 24 hours after that and a single dose 24 hours after that. So wrapping 4 tablets around an episode of condomless sex. And that has been shown, and in this study was just in gay men having anal sex, to be as effective, equally effective as taking PrEP daily. So to bear that in mind, know that there's different dosing. And the other thing I would say is look out for the new updated PrEP guidelines when they come out for consultation soon, because we're going to make a significant shift in our recommendations and that to recommend that event-based dosing actually is safe for everybody. So for gay men, anal sex particularly, that's double dose and then 1 dose and 1 dose after that. You need to take the post-sex doses for a little bit longer if you're having inserted vaginal sex, or if you're a trans woman with a neo-vagina, or if you're injecting drugs. So that's a double dose before and then 1 tablet 7 days afterwards. But it's a shift, a significant shift, and that's all based on really robust pharmacokinetic data. It's already out there if you're interested to learn more. If you go to the iBase website and look at their updated PrEP guideline, that talks all about this in detail, and it will be supported by the national guidelines when we get them out. So many more things to ask, but we've run out of time, unfortunately. But we hope, well, I'm not going to speak for Laura, I hope that has been useful and of interest, and we will close things there. So thanks very much for your attention and your engagement and asking all the questions.
Thank you, everyone. Thank you, Mike.
Cheers.